Hello friends, welcome back to my channel. As I have uploaded one of the video related to the acute back pain and strain or radiculopathy, today I'm going to continue the topic with the non-traumatic acute back pain and who needs MRI or how we can diagnose the case and who doesn't need imaging at the moment. If you haven't checked my previous video, I would highly recommend you to check that as well along with this one. Thank you so much. So let's get started. Non-traumatic acute back pain. That means if a patient is having back pain less than 4 weeks, but there was no trauma. No trauma means there was no accident, no fall, not a kind of any kind of trauma is there, but the patients come with a sudden acute back pain or maybe gradual increase in back pain. Then what? When do we do imaging? This whole slide is all about when do we imaging, that is when we do X-ray, MRI or CT scan. If we need it, yes, then which one? And yes, then in which situations? In old age people, patients pain more at night or awaken the patients with the pain. That means their pain are severe, complicated. So, and all the other examination, that means the patient does not have any weakness, any tenderness, no fever, no any bowel symptoms or normal reflexes. Then do we need MRI in this situation? If your answer is yes, then yes. Why? Because patient is having nocturnal back pain. That means it is the possibilities that it could be the sign of any malignancies. But here I'm going to discuss more about it. Now, do we need to go for imaging if it is acute, that is less than 4 to 6 weeks and no trauma history? If urinary symptoms or subtle anesthesia is present, yes, you have to go for emergent MRI. You don't have to wait for anything. If patient's lower extremities weakness involving multiple nerve roots, that means having a good cord of compressions, that means do the images. It could be possible that the patient is having bilateral compression, patient is having central compressions. We don't know. Any of these situations is not present in the patient, then are we suspecting any infections? Is there any fever, any tenderness on the spinal area? It's not paraspinal, it's spinal, that means midline tenderness. Any IV drug user history or any immunosuppression, let's suppose glucocorticoid taking. Then you have to do spinal MRI. If spinal MRI is not possible, then you might do the X-ray plus ESR and CRP, because these are the signs of infections. So we can check by this thing that the patient is having any infections that leads to the acute back pain. If these situations are not there, then what? If suspected malignancies, because we know that the bone metastasis is one of the very common in multiple kind of cancers. So if the patient is having any current or recent cancer history, let's suppose they have taken radiation 6 years ago, 8 years ago for their breast cancer or something, weight loss, multiple cancer risk factors, patient is smoking, could be chance of lung cancer, could be chance of bladder cancers, patient is having family history of breast cancers, patient is having any other family history, we don't know, or any kind of nocturnal pain as I was mentioning here. So yes, you have to do spinal MRI and you need to do ESRVS CRP also. If any of this thing is not available, that means there is no urinary problem, no sudden anesthesia, no weakness, no infections, no malignancies. We call it uncomplicated back pain. That's why no imaging is needed. So always make sure don't do unnecessary, but don't underrate the pain of the patient. So we have to stepwise remember the things. If you find any back pain with any complicated issues, you can do MRI. I will just quickly go with my previous page, which I have discussed in my last video, to just show you where we do MRI. Okay, so this is the main thing. High risk features in back pain, consider MRI if any of the following is present. Any cardiac vena syndrome present, that means urinary retention, subtle anesthesia. Any spinal infections, that means fever, immunosuppressions, IV drug uses. Malignancy, any current or recent, or unexpected weight loss or nocturnal pain or something. Other, any kind of weakness that is very bilateral or severe. Any focal spinal tenderness, that means midline tenderness, patient is having coagulopathy, or patient is more than 50 years. This, we might remember everything from here to here, but we might forget this one. So I'm just highlighting this one, that 50 years is very, 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 very important if a patient is coming with the age of 50 years. Why? Because chances of osteoporotic degenerative changes in that patients are high and leads to compressions, fractures. We don't know. So we have to do that things, okay? Now I'm going to the next topic, that is about lower back pain and the chronic situations. When do we say chronic? When it's more than 12 weeks. Let's suppose patient comes to us with the pain which is gradually increasing and it's been 15 weeks. Patient come to us with the pain. We have to ask number one questions. Any history of trauma? No? Okay. Long-term pain? More than 12 weeks, no fever, no weight loss, no radicular pain, that means no signs of radiculopathies, no weakness, no urinary symptoms. Is the pain related to their occupation? Patient is heavy lifting. Pain versus during the day and relieved by rest. If they are taking rest, then they have less pain. And flexion and extension of the spines increases the pain. That means when they are doing exertional activities, the pain increases, but they are not doing anything, pain does not increases. And straight leg raise test is normal. Tenderness positive at the paraspinal tissues, but no midline tenderness. That means this pain is not related to the vertebral column itself. It is related to, could be related to their muscles. Pain resolved by pain medication during the acute phase. So this one is basically, we can say, refractory kind of lower back pain in an acute situation. We couldn't find anything complicated symptoms, but we just say that the patient is coming with pain for longer time. How do we see pain more than 12 weeks? These are the clinical features. Number two, no evidence of specific etiology we find. We always think about malignancies, we always think about infections as well as the fractures. It could be patient is 60, 70 years old, osteoporotic patient, taking glucocorticoids or something. Chances of fractures are very, very high. Straight leg raise test, negative, no weakness. Everything seems to be fine other than having an paraspinal kind of tissue pain. Then what are the treatment options? Same as we do in the acute. We start with the normal maintaining activities, stretching and strengthening exercises programs are very helpful, or heat, acupuncture, massage could be one of them. Pharmacologically, NSAIDs, acetaminophen. Non-benzorelaxants are okay. What other we can give which we are not giving in an acute phase? This is different from which I haven't studied in the first topic in my last video. Duloxetine, TCAs or tramadol. Tramadol we might be giving in an acute phase in a refractory or severe form, but duloxetine or TCAs are new medications which can be used in a patient who coming with the 12 weeks or more of pain. So these are all the management options of patients with non-complicated lower back pain in a chronic situation. What are the different causes of lower back pain? There are multiple causes. Patient can come with strain, but what else? We have here, number one is mechanical cause, number two is radiculopathies which we call herniated disc, number three is the spinal stenosis, number four is inflammatory options, number five is metastatic cancers and infections. These infection and metastasis we are keep talking about because we don't want to forget these ones when we are ruling out the back pain in acute or chronic situations. So mechanical one is muscle strain, paramuscle spinal strain, disc degeneration, anything could be possible. There will be no neurological problems and midline tenderness will be negative, but lateral paraspinal tenderness will be positive in this situation. What are the radiculopathies? As I already mentioned to you before, that the radiculopathies means the pain is radiating up to the heel, up to the toe, or up to the foot, up to the foot. So that means this is radiation below the knee. Number 2, positive straight leg raise test. One of the best examination we can rule out. And neurological deficit could be present because this is herniations of disc. So that means cord compression could be there. Spinal stenosis. Spinal stenosis is basically 2 things I would like you to remember. Number 1 thing is patient will come with the symptoms as same as a claudication symptoms. Claudications means we were talking about vascular claudications. But in this scenario, it is definitely not because of the vessels. Symptoms are that it's the same as vascular claudications. That's why we can say this name as a pseudo-claudications. And spinal stenosis patient will always say that when we are doing bicycling or we are leaning towards the cart or the cane, our pain relieves. But if we are going downhill, it's more increased. If we are going uphill, it's more decreased, because due to their stenosis, when they are doing the extension of their spinals or the flexion of the spinals, it depends in which situation. If they are curving up their body, then the stenosis are helpful, and the stenosis is relieved in that situations and their pain goes away. But when they are going downhill, they are trying to straighten their vertebral column, and that situations the stenosis become more worse and it leads to more pain to the patient. That's why. Inflammatory spondyloarthropathy, that is worse with rest and better with activities. In inflammatory patients, they cannot rest. If they do rest, the pain increases. Sacroiliitis could be one of the things seen in inflammatory. Metastatic cancers, definitely here patient will having worse pain at night. It cannot be relieved by rest, because at night everybody is resting, but they have more pain. So, and third thing is advanced age, because metastatic cancer usually seen in patients who are more than 50, they have a weight loss history, or they have a primary cancers or anything related to that. Infections. So infections means osteomyelitis. There is one more, discicitis, that is recent infections, IV drug users, fever, or any kind of midline tenderness. So these are all the 6 different kinds of categories which can seen in a patients who come with the lower back pain in a chronic situations. I'm going to discuss further about it in the next video, and stay tuned and make sure you check my previous video too.